A very good evening and a warm welcome to everyone who have joined us this Saturday evening. So today we are having another session in the series of NEFFRON, an expert curated lecture series for physicians dealing with kidney disorders. The aim of the NEFFRON program is to bridge the knowledge resource gap that exists in between the physicians and the diabetologists in kidney disease management. As we are all aware that the nephrologists, the specialists, are not, there are low number of nephrologists in India. So physicians being the primary point of contact, it is necessary that we address the challenges associated with the kidney disease management. So today, I would like to introduce our clinical expert who will be sharing some of the views on diabetic nephropathy and the role of physicians in that. So I will introduce our clinical expert and welcome him, Dr. Shanmugaraj. Dr. Shanmugaraj is a consultant in nephrology, heading nephrology, hemodialysis unit, and CAPD program in Sangam Hospital, Palakkad, Kerala. He has been a recipient of gold medal in DNB nephrology, in Dr. HL gold medal in DNB nephrology for topping all India in DNB nephrology exam. His former experience as head nephrology unit, tertiary care hospital, armed forces, and worked in the Indian Army since 1996 as a medical officer of Indian Army, have worked in Udhampur and Doda district of Jammu and Kashmir. Following his MD internal medicine at AFMC, Pune, he has worked as a consultant medicine at military hospital in Kamptee and Bikaner. Has also worked as a specialist in internal medicine on behalf of the Indian Army at United Nations hospitals in Lebanon and Democratic Republic of Congo. With this, I would like to welcome Dr. Shanmugaraj and address the audience with his views on diabetic nephropathy, the role of physicians. Over to you.
Thank you, Anjali.
Yes,
So, let me.
yes, sir. Now you can share your
Yeah,
screen.
my screen share is disabled.
Yes, now you can.
Yeah, is it visible now?
Yes, sir, it is visible.
Yeah. So, good evening, ladies and gentlemen. So, today we'll be talking about diabetic nephropathy and the role of physicians as regards to diabetic nephropathy. This is yesterday's newspaper in Times of India, where it says 100 million plus Indians are now diabetic. That is up to 44% in the last 4 years. This is as per a ICMR study. So there is definitely an epidemic of diabetes in India. It is not only in India, it is a global phenomenon. Right now, there are 425 million people with diabetes, and it is expected to really go up during the next few decades. Diabetes has emerged as a leading cause of end-stage renal disease in the world. The global prevalence of diabetes projected to increase from 537 million presently to around 783 million by 2040. Now, if you look at diabetic kidney disease, that is close to around 20 to 30% of this. So we have a huge number of new patients who will be now suffering from diabetic kidney disease. The management of diabetics with CKD, it continues to be complex and challenging. Now, if you look at the number of patients who start dialysis, close to 50% of the patients are diabetics. Glomerulonephritis accounts for around 13%, hypertension for around 30%. All the other causes put together come to around 10%. So, around, or rather majority of the patients who start on dialysis in any center are likely to be diabetic. The predisposing factors for diabetic kidney disease include a positive family history, race specific, this being mostly US data. We have like African American descent, Hispanic, or Pima Indian. Pima Indian particularly are highly prone to renal disease because of diabetes. Obesity, a leading cause, then poor glycemic control and poor blood pressure control. Diabetic nephropathy, it's a clinical syndrome where the clinical hallmark is the presence of protein. There is increased urinary albumin excretion. If you look at pathophysiology, there is expansion of mesangium, there is glomerular basement membrane thickening, and glomerular sclerosis. For this particular presentation, we are not going to be looking at the pathophysiology and the pathological features in diabetes. We'll be looking mostly at the clinical aspects. The lifetime risk of developing diabetic nephropathy is similar for type 1 and type 2 diabetes. So if you look at the epidemiology, 25 to 30% of type 1 diabetes develop nephropathy. Type 1 diabetes, by nature of its disease, is detected very early, and diabetic nephropathy usually starts developing after 5 years, and overt nephropathy after about 10 years after the development of diabetes. When it comes to type 2 diabetes, 30 to 40% develop nephropathy. However, type 2 diabetes is detected very late, and a lot of patients already have nephropathy by the time diabetes is detected. So we cannot really define a time frame for development of nephropathy in case of type 2 diabetes. The ratio of type 1 to type 2 is about 1:10. So mostly, that is more than 90% of diabetic nephropathies would be because of type 2 diabetes. Approximately 50% of this type 2 diabetes, they will go on to develop diabetic kidney disease. We'll come to this particular term, diabetic kidney disease, later on. Only 2/3 of patients will exhibit the typical features of diabetic nephropathy. They will have, 1/3 will have all kinds of atypical features. Ischemia and non-diabetic renal disease account for the remainder. Now, how do we diagnose diabetic nephropathy? So, the clinical criteria for diabetes of diagnosis of CKD in diabetes would be the presence of a decreased glomerular filtration rate, that is less than 60 ml per minute per 1.75 meter square. This estimated GFR is to be calculated from the various calculators using serum creatinine levels. The preferred one would be the MDRD formula. The urinary albumin creatinine ratio should be more than 30 milligram per gram, or urine albumin excretion rate, if you're doing a time collection, should be more than 30 milligram per day. If this criteria is present for more than 3 months, we can make a diagnosis of diabetic nephropathy. So coming back to measurement of albuminuria, normal albuminuria is less than 30 milligram per gram. That is, if you're doing in a spot sample, what we call as albumin creatinine ratio, if there is less than 30 milligram per gram of creatinine, that is 30 milligram of albumin less per gram of creatinine, we call it as normal albuminuria. And if you're doing a time study, it will be less than 30 milligram per day. Microalbuminuria is between 30 and 300 milligrams per gram. And if you're doing a time study, it is 30 to 300 milligrams per day. Macroalbuminuria is anything more than 300 milligrams. This cannot be, like, we cannot make a diagnosis on a single value. We have to have at least two values which are separated by at least 3 to 6 months. So typically, if you look at the epidemiology and the natural history of the disease, when does a nephrologist get involved in diabetic nephropathy? Usually it is when the patient is referred to the nephrologist. In case of type 2 diabetes, by the nature of its illness, the patient is referred very late. The patient already has microalbuminuria or overt albuminuria. A lot of times the patient comes to us in renal failure and the patient is almost at the verge of starting dialysis. Type 1 diabetes, because it is diagnosed early, we normally pick it up much earlier. Now, a diabetic, though he is prone to diabetic kidney disease, can suffer any other kidney disease which can be suffered by the normal population. So, whenever we see a renal disease in a diabetic, we should not straight away make a diagnosis of diabetic nephropathy. We have to look at the other etiologies, or rather exclude other etiologies. So if we have a diabetic kidney disease, the classical diabetic nephropathy would be just about 40 to 50% of the patient. The other patients will have nephrosclerosis because of hypertension, can have a gouty nephropathy, can have other atherosclerotic disease, dyslipidemia related diseases. The diabetic is also prone to all other disease. So a patient with diabetes can have any glomerular disease which the normal uh, person in the community can have. He can also have genetic diseases like ADPKD, he can have interstitial nephritis. So in a study like which analyzed about 250 patients who who were diabetic and had renal failure, they found roughly 53% of the patient had a non-diabetic kind of renal disease, out of which like 21% were because of FSGS, minimal change disease was there in about 15%, and the other glomerular disease contributing to the rest. So we should never ever assume that a patient with diabetes and a renal dysfunction is because of renal disease. I mean, because of diabetic kidney disease. This is probably the most important slide in this presentation. So whenever we have a patient with diabetes and proteinuria, we should exclude certain things. We should exclude a urinary tract infection. We should exclude signs and symptoms of other non-diabetic kidney disease. For example, urine microscopy should not show red cells. Urine sediments in diabetic kidney diseases typically bland. If it has RBCs, it will be just less than 10 in number per high power field. We have hematuria, or if we have massive red cells in the sediments, we should consider an alternative diagnosis. Again, if ultrasound of the kidney shows a shrunken kidney, again we should consider alternative diagnosis. Then, if clinically, if other glomerular nephritis is suspected, we should screen for other diseases. For example, might require complement levels, might require ANCA studies, and serum electrophoresis if we are looking for myeloma. So we should consider renal biopsy to consider or exclude other diagnosis if retinopathy is not present in a type 1 diabetes with proteinuria and impaired renal function. We have to exclude other diagnoses. However, in type 2 diabetes, the absence of retinopathy does not exclude diabetic kidney disease. That is because in type 1 diabetes, when they go on to develop nephropathy, around 95% of the patients also have retinopathy. However, this correlation does not hold true in type 2 diabetes. If at the onset the proteinuria has been sudden and rapid, again it goes against a diabetic kidney disease. Usually in diabetic kidney disease, the proteinuria is very gradual. It usually goes through a stage. The patient has normal albuminuria, then develops microalbuminuria, and over months to years, the patient develops frank proteinuria. However, if there is an abrupt onset of proteinuria, it goes against the diagnosis of diabetic kidney disease. So, if the evolution is without transition through the usual stages, we have to consider another diagnosis. Again, development of nephrotic syndrome without previously moderately increased albuminuria, again, goes highly against a diabetic kidney disease. If there is macrohematuria or active nephritic urinary sediment, again, it is extremely unlikely to be a diabetic disease. Again, if the decline in kidney function is rapid, again, we have to consider other diseases. Of course, we would have excluded reversible causes of AKI here. Again, if there is renal dysfunction but without proteinuria, again, it goes against diabetic kidney disease because diabetic nephropathy, the main feature is presence of proteinuria. So, which are the factors which affect the rate of progression of diabetic kidney disease? One is age at diagnosis, elderly patients, then non-modifiable risk factors are age at diagnosis and family history. Like if there is a family history, if there is somebody on dialysis in the family because of diabetes, this patient is also likely to go into dialysis. Male sex, again, slightly more prone to diabetic nephropathy than females. The modifiable risk factors are alcohol use, hyperglycemia, that is poorly controlled diabetes, smoking, hyperlipidemia, poorly controlled hypertension, and presence of obesity. Now, this is the natural history of diabetic nephropathy. The patient like this basically is in type 1 diabetes. Like by 5 years, there is increase in GFR, where there is hyperfiltration. There is increase in GFR, which goes on and then followed by a decline in GFR. And it comes back to normal. At this stage, we call it as pseudo-normalization, following which this usually happens at around 10 years and then gradual there is a decline in the GFR. Pari passu with this, there is a slight increase in albuminuria, which as the GFR declines, it starts increasing. So if you look at the natural history, the percentage of patients who are likely to progress to each stage, around 50%, that is around incidence would be around 2 to 4% of the diabetic population per annum, they go on to microalbuminuria. Around 30% of them, they are lucky, they just continue to have persistent microalbuminuria. However, 40% would go into frank proteinuria. And once the patient goes into frank proteinuria, the disease is relentless. They will almost always go into renal failure. They will require renal replacement therapy. So how should we screen? Microalbuminuria is the earliest detectable marker of diabetic kidney disease. So our screening will mostly be on the presence or absence of microalbuminuria. Like a patient with type 2 diabetes after 5 years has to be screened every year, and type 2 diabetes has to be screened from the time of diabetes at least once in a year, should be screened for presence of microalbuminuria. If there is hypertension, irrespective of the duration of the diabetes, we have to keep screening for again DKD. Now coming to management. So these are the landmark trials which changed the way we treat diabetic kidney disease. In 93, ACE inhibitors, they were found to be beneficial. That is CST captopril. In 2001, we had two landmark trials, IDNT and RENAL, which again showed ARBs to be non-inferior to ACE inhibitor, and they all became mainstays of treatment of diabetic nephropathy. There was not much change in our management till about 2013 to 2015, when a lot of new research showed up new possibilities. One was the EMPA-REC outcome, the CANVAS, DAPA-CKD. They showed the benefit of SGLT2 inhibitors, and which showed massive benefit to patients who are on these two drugs. And other landmark trials are ARTS, followed by Fidelio and Figaro DKD. They showed the benefit of mineralocorticoid receptor antagonists in again preventing or retarding the progress of diabetic kidney disease. So how do we manage this? So all patients should be, like, the basics are to be followed for all patients. We should have good glycemic control. The blood pressure control has to be good. There should be a good lipid management. If the patient is a smoker, he has to stop smoking. The patient should have an optimum amount of exercise. Optimum exercise which is recommended is 30 minutes at least 5 times in a week. And nutrition, where mostly we should be concentrating on restricting protein intake to around 0.5 grams per kg of body weight. And most patients, if there are no contraindications, should be getting SGLT2 inhibitors and RAS blockade. Some patients, especially if they have a vascular disease, coexisting cardiac disease, they should be on antiplatelet therapy. So before we go into the other medication, we have to follow the basics. Glycemic control is the most important thing. Without glycemic control, all other therapies, all other interventions would be next to meaningless. Blood pressure control, equally important. And if anybody has dyslipidemia, it has to be well controlled. And dietary modification, we will not go too much into detail in this particular presentation. So glycemic control first would be increasing the physical activity. Diabetic diet has to be followed, and if a patient is obese, should aim at weight loss. The first line therapy for control of diabetes, for glycemic control, should be metformin. If the patient's GFR is more than 45, metformin should be the first line therapy. If it is less than 45, we should use 50% of the dose, and less than 30, we should discontinue. So all patients should be on metformin till they drop below a GFR of 30 milligram, 30 ml per minute. If a patient is on dialysis, again, patient should not be on metformin. SGLT2 inhibitor, again, all patients, if there are no contraindication, if the GFR is more than 20, they should be given SGLT2 inhibitor. It should be discontinued once the patient reaches dialysis. To support this, second line, third line anti-diabetic drugs, we have a choice: insulin, DPP4 inhibitor, sulfonylureas, alpha-glycoside inhibitor, and GLP-1 receptor antagonist. GLP-1 antagonist, there are a lot of studies going on, and it is likely to come up as a very important drug. But right now, because of the cost availability factors in India, it is not a mainstream drug for treatment of diabetes as yet. So what should be our target HbA1c? So KDIGO has not given a particular level. They have given a individualized target for control of glycemic control, that is ranging from HbA1c from 6.5 to 8%. So it would depend on the severity of the CKD. A patient who is, say, CKD 5 will probably not be able to tolerate a very, very tight glycemic control. So in them, even HbA1c of 8% would be acceptable. Again, a patient with macrovascular complication, if they are present, again, tight control is going to be difficult. So we have to individualize this control as per the comorbidities present with the patient. The hypertension control, various societies have given various targets. So KDIGO also follows the ACC-HA target, that is, the systolic should be less than 130 and the diastolic should be less than 80 millimeter of mercury. So which should be the mainstay for controlling of hypertension? It has to be ACE inhibitor oblique ARBs. Between ACE inhibitor and ARBs, there is little to choose between. Both of them can be used interchangeably. Clinically, for us, like ARBs are slightly superior because the side effect profile is slightly better. So all patients, unless there is a contraindication, should be exposed to ACE oblique ARBs. So these are the landmark trials which showed massive benefit with this RAS blockade. So how do we go about controlling blood pressure? The first line drug should be ACE oblique ARBs. We should titrate to the maximum tolerated dose. We should also follow it up with a low sodium diet. We should try to aim for a 2-gram sodium diet. The second line drug should be a diuretic. If the GFR is more than 50 ml per minute, thiazide is acceptable. If it is less than 50 ml, thiazides, they tend to be not very effective. A loop diuretic would be a better choice. Then we have choice, third line, a long-acting calcium channel blocker or a beta blocker. A fourth line, we can have an alpha blocker or clonidine. And like even if they are still refractory, then we can think of minoxidil. Now this goes slightly different from for the normal population, where the fourth drug right now the recommendation is for spironolactone. Spironolactone, when it is combined with ACE oblique AR, it causes too much of hyperkalemia, unacceptable hyperkalemia, and should be avoided. So whenever we initiate ACE or ARBs, we should monitor serum creatinine and potassium within 2 to 4 weeks of starting the treatment or changing the dose. If there is normokalemia, we can go on titrating the dose. If there is hyperkalemia, we should review if there is any other concurrent drug which is adding on. For example, if there is a spironolactone which is there along with the ACE, it has to be stopped. We should also try to reduce the potassium intake in diet and also consider adding on a loop diuretic, which would also cause some chalciuresis and bring down the potassium level. SGLT2 inhibitor now come in a big way. These are the major trials which have shown like very, very definite benefit because of this, it has benefit both in cardiovascular disease and in diabetic kidney disease. We will not go into details of these trials. The new drug which is now coming in is the non-steroidal mineralocorticoid receptor antagonist, that is finerenone. Again, these are the major trials which have shown again benefit in diabetic kidney disease. Basically, they help by reducing the progression of CKD by reducing the fibrosis inside the kidney. So this is the Fidelio DKD, which showed consistent benefit on kidney and cardiovascular outcomes. So finerenone, the target dose would be 20 milligram per day, and if the GFR is less than 60, we should start with 10 milligrams per day and try to titrate it up to 20 milligrams per day. We should stop these drugs once the GFR reduces below 25 ml per minute. So to summarize, the pillars for treatment for diabetes would be glycemic management, blood pressure management, lipid management, and other agents for benefit with cardiovascular and kidney diseases. For example, statins and antiplatelet drugs. Now, the new drugs which are coming up in a big way and which are to be given in all patients unless there is a contraindication are one is RAS blockade, second would be the SGLT2 inhibitor, and the non-steroidal MRAs, which are already available and which are already in clinical use. So this is again summarizing whatever we have spoken till now. Thank you.
Thank you so much, sir. It was a very comprehensive and insightful talk on diabetic nephropathy. There are a few questions, sir, that has come up. One thing regarding the diagnosis of diabetic nephropathy. Although we are aware that albumin is one of the early markers of diabetic nephropathy, sometimes the albumin is not detected in the early stages until then the glomerular damage has already happened. So, any insight on the new markers or any way that, apart from albumin, that the doctors can detect, the physicians can early detect?
See, whenever there is reduction in the renal function, that is the GFR is reduced and there is no albuminuria, it usually suggests an alternative diagnosis. However, there is a subset of diabetic kidney disease which are normoalbuminuric, but that is more of an exception rather than the rule. Majority of the patients who do not have albuminuria would be having some other renal disease. They would be having a atherosclerotic disease, ischemic nephropathy, or interstitial nephritis. So it is unlikely that they would be having diabetic kidney disease.
Okay, sir. Sir, at what stage do you recommend biopsy to be done for diabetic nephropathy to differentiate between the glomerular nephritis and diabetic nephropathy?
Sorry, I didn't get your question.
Sir, at what stage do you recommend having biopsy done, renal biopsy to the patients to differentiate between the glomerular nephritis versus the diabetic nephropathy?
Yeah. So, diabetic nephropathy is basically a clinical diagnosis. We do not do a biopsy for any patient for diagnosing diabetic nephropathy. It is an assumed diagnosis in a diabetic patient with reduced renal function and proteinuria. If the urine does not show any active sediments, the ultrasound does not show any abnormal features, that is usually the kidney is not shrunken. They are normal in size at the time of diagnosis. We make a diagnosis of diabetic nephropathy. So if any of these factors are not there, for example, there is massive proteinuria. For example, you have say 15 grams of proteinuria with a say GFR of around 60. This would suggest some other glomerular disease rather than, so in this patient, we would definitely do a biopsy. Again, if there is a RBC cast in the urine, again, we should do a biopsy, which could be suggesting a diagnosis of RPGN. So the essential point is for the physicians, because they would be the patient, ones who would be seeing these patients, they should be referring such patients. Anything which is not fitting into the classical diagnosis of diabetic nephropathy should be referred to the nephrologist for further evaluation, and that further evaluation would mostly be renal biopsy.
Okay. So any hesitation that you have noticed in the patient while they are undergoing biopsy from the patient's
Obviously, like
perspective?
there is always a hesitation because every patient is scared of any intervention, especially any invasive procedure is scary. And however, in today's world where we are doing biopsies with ultrasound guidance, the complication rates are very, very low. Though it is not zero, it is like very, very minuscule. It is a very safe procedure. But to convince a patient at times can be difficult. A lot of patients, they miss the diagnosis because they refuse to undergo biopsy.
Correct, sir. So there's one question regarding the use of NSAIDs in the reducing the inflammation in glomerulonephritis. So what is the treatment protocol they should follow in glomerulonephritis?
Like NSAIDs should be universally not used in any glomerulonephropathy because they have a tendency of causing further renal damage. By
Okay.
inhibiting prostaglandins, the afferent arteriolar vasoconstriction might occur and it can cause, like if used for a consistently long time, it can cause permanent damage, or if used for a short time, it can cause a acute kidney injury. So as a whole, that whole group of drugs should be avoided in any patient with reduced renal function.
So what do you recommend for the inflammation to reduce the inflammation in the patients?
So right now we have a new drug that is the non-steroidal MRA. That is right now we have finerenone. It is by reducing the mineralocorticoid, by blocking the mineralocorticoid receptor, it reduces the inflammation, fibrosis inside the kidney. So right now that is the only approved drug which can be used for. Now there is a huge list of drugs which are undergoing trials, but a lot of them have not shown the initial promise. Some of them are in phase 2, some of them are in phase 3 trials. Probably in the next few years, we'll have new agents coming up. But as of now, we do not have any particular drug apart from this particular finerenone, which can reduce the inflammation in the kidney.
Yes, sir. So regarding the hypertension control in diabetic nephropathy, so one must initiate with the monotherapy of ARBs or they should go with a combination.
Now, that's a very good question. Now, monotherapy is normally not resorted to unless the blood pressure is on a very, very, like we have just stage 1 hypertension. If somebody comes with stage 2 hypertension, the current recommendation is to use at least 2 agents. One of the agents should be AS oblique ARB. The second is choice between say calcium channel blocker, or you can use alpha blocker. Like we have a lot of drugs which can be used in place of that. So we should usually not resort to monotherapy.
Okay, sir. So any diet recommendations for the patients with diabetic nephropathy? What diet therapy they should
Yeah.
go across?
So, like I personally feel all dietary recommendation in diabetic kidney disease. I'm not talking about diabetes. For diabetic kidney disease, they are overhyped. Like the amount of evidence of the benefit because of very rigorous dietary restriction. Basically, when we say dietary restriction, we mean dietary protein restriction is not very, very good. There is definitely some benefit, but not to the benefit that it is sort of like people are exposed to. So the recommendation right now is to have zero point 0.8 grams of protein per kg. That is a 60 kilogram person should not take more than 40 gram protein in a day. And Indian diet is already protein restricted. Now, if the patient starts to cut down protein on top of that, we will have sarcopenia because of protein deficiency. So a lot of times this protein restriction is counterproductive because it is not followed the way it should be followed. This protein restriction, it usually comes from the Western literature where the Western diet is very, very protein rich.
Correct, sir.
We cannot extrapolate it to our Indian diet.
Okay, sir. So one take-home message for all the physicians and the diabetologists who are watching this session. Anything from your side?
So, firstly, like as I told you, the most important slide was to exclude alternative diagnosis. We miss the bus in diagnosing. We have very narrow window because a RPGN or I say a glomerular disease will not give us much time for diagnosis and treatment. If you have persistent proteinuria for more than few months, the disease is already progressing and untreatable. So we should never ever miss, because if you see anything odd in the progression of a diabetic nephropathy, the patient should be immediately referred to a nephrologist. Otherwise, referral to nephrology is recommended once the patient reaches CKD stage 3.
Thank you so much, sir. With this, we come to an end of the session. And I would really like to give a vote of thanks on behalf of the Saffron family to Dr. Shanmugaraj for joining us despite his very busy schedule and giving a very comprehensive and a detailed presentation on diabetic nephropathy. Some of the slides he also showed examples, and with the news which has been recently highlighted on the number of diabetic population that is increasing day by day. So, lastly, I would like to thank the audience who have attended this today's session. And for your information, this will be available on YouTube and can be watched anytime. And we have Dr. Shanmugaraj to address any questions. So, if in case you want to post any questions on YouTube, he will be available to answer those queries to you. Thank you so much, sir, for joining in today. And we look forward to your support and guidance in our further initiatives to come forward.
Thank you.
Thank you so much. Thanks a lot.